Sure.
Good evening, all. India Spine welcomes you all. So, we bring you the second on series of webinar aimed at enhancing and bridging the gap between the understanding from physiotherapist point of view and surgeon points of view. What is the surgeon's perspective? Knowing what surgeon wants and knowing what we physios are trying to achieve helps both surgeon and physios to improve the patient care. So today we have one of the best spine surgeon with us to share his perspective. So I invite Dr. Arvind Kulkarni. A brief about Arvind sir. Sir is one of consultant spine surgeon at Bombay Hospital, Bridge Candy and Saifi Hospital. He is the pioneer of minimal invasive spinal surgeries and artificial disc replacement in India. He has presented research papers nationally and internationally and also won the best paper awards and also he has numerous scientific publications to his credit. Not only this, but he is also on the editorial board of many international and national journals. So I welcome Arvind sir to share his perspective with us today.
Yeah, can you see my screen?
Yes, sir.
I thank Dr. Kavita for this great opportunity. So physiotherapists form the spine of my practice. We both are partners in crime. I mean, I'm just kidding. We are partners in health. So alone we cannot do much. Only when we join hands that we can rescue our patients from their illness. And it is very well known and it's very well understood by me in my 13 years of practice. So teamwork is very, very important. The synergy that a team has always delivers optimum results, when compared to a one-man show. So this talk I was wanting to give for a long, long time. This is actually my first address to any physiotherapy faculty at large, and I wanted to deliver it for a long, long time. And this COVID-19 has made it manifest. So in a mean way, I'm thankful to COVID-19. So to benefit our patients, it's very important that we as well as the physiotherapists are on the same page, because many a times it happens that there is a difference in the point of view, and that creates confusion in the patient as well as in both the treating groups, that is the surgeons as well as the physiotherapists. Now look at this slide. So one common denominator in this slide is that everyone here has back pain, but it's very well known that the causes of back pain are totally different in all these patients. Same again, all these gentlemen, they all have leg pain. That is a common feature of this slide, but they have totally a different range of origins for the leg pain. So it's very important for us to understand spine. We need to understand the anatomy and physiology, because that lays the foundation to understand the biomechanics, to understand the evolution of conditions, to choose the appropriate investigations, to formulate treatment, and to formulate rehab protocols. Spine is a very vast subject. I will be touching mainly on the degenerative part today, and that too more specifically to the lumbar spine. That itself will probably take 1 hour of our time. So as you know, it's a S-shaped curve for various reasons, for resilience, for maintaining the center of gravity, etc. So the maximum amount of stress in the lumbar spine is at the L4, 5 and L5 regions. So 60% of the movement and 60% of the weight bearing happens here. And the architecture is such that, there is alternating set of bones, which we call vertebrae, and between two vertebrae there is an intervertebral disc, and the lumbar spine is lordotic in nature. So the basic elements of the bony skeleton are the vertebral bodies. So these are these we can call them elements. So in a cross section, this forms the chunk of the vertebra. This is the vertebral body. The significance of vertebral body is that tumors, infections, they start here, because it is rich in cancellous bone. All this porous structure that you see in this cross section, it's all blood vessels. It's bone marrow basically. So it is very, very rich in bone marrow. That's why it can harbor metastasis, it can harbor infection, and it can be a site of origin of tumors. So that is the relevance of vertebral bodies. Then comes the pedicles. The pedicles are the strongest part of the vertebra, and these are the means. These are the means by which surgeons take purchase into the vertebral body with what is called as pedicle screws. They are very, very important and relevant to the surgeons when it comes to surgery. And so the vertebral body forms the anterior column, and the posterior column is formed by the pedicles. So these are called transverse processes where muscles are attached. And this is the spinous process, and these are the laminae. So when you must have heard of the word laminectomy. So when there is congestion in the canal, when the canal becomes tight, so this is what is cut to relieve the congestion and expand the space for the neural structures which go through this hollow canal, which you call the central canal or the spinal canal. And these are the articular surfaces through which the vertebrae form joints with the adjacent vertebrae. So this is the posterior view. So this is the lamina. You can see this lamina. And this is the spinous process, and these are the facet joints. Okay, so this is an inert element that the vertebral body. The active element is the intervertebral disc. So this is an extremely unique structure which is not present in any other part of the body. It's a very active structure. So it has this layer of fibers which you call annulus fibrosis. They are in the form of a crisscross pattern, and they are extremely thick, very, very difficult to tear these fibers. So if you see, this is the posterior part, this is the anterior part. The anterior part of the fibers, the anterior annulus is comparatively thicker than the posterior layer. That is the reason we tend to have disc herniations at the back. And in the center lies the nucleus pulposus. So this is a jelly-like material which moves front and back depending upon the patient's position. So in flexion, it moves backwards. In extension, it moves forwards. So it is like a ball bearing. So this is very important. So from biomechanical perspective, so the spine is divided into an anterior column and a posterior column. So the anterior column is made basically by alternating arrangement of the vertebral bodies and the intervertebral discs. So this is extremely important. 80% of the human load goes through the anterior column, and the posterior column takes about 20% of the load, and this is transmitted through the facet joints and the pars. So it's very, very important that anterior column takes majority of the load. So if you have weak bones, that is osteoporosis, if you have genetically weak discs, so that might come in the way of your load bearing and give rise to pain. So this is what happens in patients who have osteoporosis. Because the bones are porous, the anterior column doesn't take load, and patients tend to have fractures at multiple levels. People tend to get kyphotic posture. The poor posture plus weak bones can add on and synergistically give rise to increasing amount of pain and disability to the patients. Again, a disc which is degenerated because it cannot take load can give rise to pain. These are all important when you apply these principles to patient assessment. So as discussed earlier, so these are the vertebral bodies, these are the discs. So when you bend forwards, so you're putting your load on the vertebral bodies and the discs, okay? And when you're bending backwards, you're taking the load off the intervertebral disc and the bodies and loading the facet joint. So in flexion, you are loading the disc and unloading the facet joint. In extension, you are unloading the disc and loading the facet joints. So again, this is very, very important when it comes to patient assessment. So you can see this video here. So this is nucleus pulposus. You can see how it is moving forwards and backwards. So how the disc, so these are vertebral bodies. So you see how in flexion the discs get loaded and how they got unloaded in extension, and how the posterior elements get loaded in extension and get stretched out in flexion. Again, this is an extremely important slide to understand the physiology and biomechanics of spine. So, this is a graph which in which the position taken by a person is pitched against the degree of the amount of pressure on the intervertebral discs in the lumbar spine. So, as you see here, in the slouch posture, the amount of pressure on the intervertebral disc is the maximum. So this is the reason why most of our patients nowadays are youngsters who sit for hours together in front of computers. They have they slumber on their discs. They have a very ignorant about spinal hygiene. So it's very important that such patients are trained and disciplined to sit in take right postures when they go to work. Again, prolonged pressure can be harmful to the discs, so it is very important for us to teach them not to sit continuously on their desks and to take breaks in between. The next worst posture would be a forward bending posture. So these are one of the reasons why we advise patients not to bend forwards when they have significant back pain, acute back pain. Again, sitting straight at 90 degrees is comparatively worse to a situation where the patient is leaning backwards. So when a patient is leaning back, when a person is leaning backwards on the table, in front of the table, on the desk, the center of gravity is passing in front of him. So that is the reason there is less load on the spine. So it's always important to advise patients to sit at about 120 to 130 degrees reclined in their working positions. And the amount of pressure on the disc is least when you're standing and when you're lying down. So this is the basis for advising bed rest to patients who have back pain. When you have significant back pain, put the patient on bed rest so the amount of pressure on the disc is at its minimum. So this is the basis behind advising bed rest. Again, the anatomy of spine is incomplete. Discussion about anatomy of spine is incomplete without discussing about the neural structures, because one of the main functions of the spine is to protect the neural structures. As you know, they start in the brain, come down. The spinal cord ends at around T12 L1 level, and then there is a what is called cauda equina, which means a horse's tail. So the nerves come into branch out into a bunch like a horse's tail, and they come out of this foramen and supply the lower limbs as well as the bladder and bowel. So till T12 L1 it is the spinal cord, and below that it is a bunch of nerves which go down to the leg, and each of these nerves goes out through this foramen, and they are numbered based on the foramen they come out from. So the L1 root, for example, comes beneath the L1 pedicle. So the L2 root comes beneath the L2 pedicle. The L3 root comes beneath the L3 pedicle. So this is how they are numbered. And as you know, any compression on these nerves can lead to neurological symptoms. So this is the cross section. So these are the spinal nerves. This is the dorsal root ganglion. Okay, so the ventral ramus is important from a movement point of view, and the posterior ramus is important from the sensory point of view. Again, this, as you must have seen this, come across this particular image on the left during your training. So the spine is compared to the mast of the ship, and for the mast of the ship to stand erect, your the ropes have to be in proper tension. So similarly, the flexors, so the flexors and the extensors of the spine of the have to be in absolute good tension to maintain your spine in shape. Any weakness from in the flexors or the extensors can lead to deformity and disability. So this is the reason behind advising patients to do daily exercises, regular exercises in their daily routine. Again, this picture is something which is extremely important when you have to apply science when you assess patients. So this the spine can be divided into a tension side and the compression side. So the tension side is made up of these posterior elements. So these are spinous processes, and connected to each spinous process is a interspinous ligament. So this is like a rubber band going from top to bottom. This is a tensile surface. If there is any injury to the tensile surface becomes weak and the spine tends to bend forwards. So then it will be a failure of tensile surface, and because it starts bending forwards, there is increased stress on the compression side, that is on the intervertebral discs and the vertebral bodies. And if the intervertebral discs are degenerated, there is failure, or the vertebral body fail because of either osteoporosis or because of trauma, because of a failure of the tensile surface. Then there will be increasing deformity, and this deformity can lead to worsening disability in terms of back pain, discomfort, and in worst case scenarios, because of increased kyphosis, one can have compression of the spinal cord and consequent neurological symptoms. So it is very important to have a good balance of the tensile and compression surfaces, and that is possible only by doing regular exercises and strengthening your back. So this is something all of us learned during our orthopedic training. So this happens in every patient, in every person across the population. So this is called a degenerative cascade. So every disc undergoes goes through this process of degenerative cascade. It starts initially in the lower lumbar vertebrae, that is L4, 5, L5, S1, because they take the brunt of all the stress. So it starts with the degeneration. So basically, you've seen the previous slides. So there is annulus fibrosis, 3 layers of annulus fibrosis, inside which there is nucleus pulposus. So the nucleus pulposus gets dehydrated over a period of time. When it gets dehydrated, it cannot take stress. So something that is like a jelly becomes hard, and it cannot take stress, it cannot take the load, and it loses its elasticity, because of which the annulus tears. So the load is transmitted from the nucleus to the annulus. So this is the time when one can get back pain, and this back pain is discogenic because the disc undergoes wear and tear. The nucleus pulposus becomes hard, so the back cannot take load. So then this is called discogenic pain, and because it is the anterior column, these kind of symptoms come when the patient bends forwards. So that is one cause of back pain which can happen in disc degeneration, and this happens in early stages of life, that is between 30 and 45 years of age. So at this is the same time, as I said, there is failure of nucleus pulposus giving rise to back pain. Then the annulus fibrosus tears. So that is called annular tear. So that can cause back pain. The annular tear can cause pain in the center or on one side, either the right or left, depending upon where the tear is. And it is the same time that, the nucleus pulposus can jet out of the annular tear and cause a disc herniation, leading to, manifestations of leg pain, paresthesia, etc. So disc degeneration, this is in the early part of life, you can say middle age. So this is the time one can have back pain because of disc dehydration, because of annular tear, and one can have leg pain because of herniated nucleus pulposus, that is a disc herniation. Then because there is degeneration of the disc height reduces. When the disc height reduces, there is increased load on the facet joints, and these issues cause what is called instability. A disc which was tall becomes short. So this disc which was of this height, as shown in this arrow here, as this arrow denotes, over a period of time the disc shrinks in size. So because of that, there is instability. Okay, the disc loses its height and there is increased load on the facet. This is the time when there is instability. This is the time when this happens in a slightly higher age group, that is around 45 to 60. So this is called mechanical instability. So patients complain of mechanical instability. So basically when they change positions, etc. Similar is the pain of facet origin. And at the same time, because of facet hypertrophy, degeneration, the foramen become narrow. And when the foramen become narrow, the nerves get compressed. And when the nerves get compressed, you get stenosis. And this happens usually in, this pain comes about when you stand or walk. That is, the foramen size gets compromised when the patient extends his back. So when you extend your back, you get foraminal stenosis that causes leg pain. So this happens during the stage of instability. And in the stage of stability, over a period of time, the entire segment becomes stable because there are osteophytes formed. So these osteophytes, they give stability to the spine. So they are not a disease. So this osteophytes help, they bridge across the intervertebral disc. And you can see, because of osteophytosis, there is also foraminal narrowing. So because of osteophytes at the front and the back, the spine becomes stable. And if at all they have pain, the pain is usually again on extension, and that is of facet origin. And because of the foraminal narrowing, again, patient can complain of leg pain. So what I mean to say is, in the early part of the life, so if there's a middle-aged person who comes to you with back pain, it's usually discogenic in nature. If an elderly patient comes to you with back pain, it's usually facetogenic in nature. And if the patient, if the patient is middle-aged and if he complains of back pain, it's usually flexion dominant pain, because it is usually coming from the anterior column, that is the disc and the annulus. And if it is an elderly patient, it's usually coming from the posterior column, that is the facet origin. Again, if the patient who is young comes to you with leg pain, it's usually again an anterior column issue because of a disc herniation causing leg pain. Again, this is flexion dominant. It comes on bending forwards because of anterior column being loaded. And again, in elderly people, the pain is usually comes on extension. That is because of foraminal narrowing. So that is extension dominant. So this particular degenerative cascade explains a lot of conditions that we see in our practice, and it is very important to register it in your mind. So as I said, most of the conditions that we see, they are byproducts of degeneration. So again, this degeneration also explains many of the other pathologies that we see in our practice. So the disc degeneration can be asymmetrical. Okay, so this is the right side, this is the left side. If there is more disc degeneration on one side, if it is unequal, asymmetric, then what will happen is, over a period of time, because of increasing load, the wear and tear keeps increasing on the same side, and the convex side is hardly any degeneration. So if you see here, this is a CT scan. you can see there is the disc degeneration has started here, okay, at L5S1 on one side, but the convex side, there's hardly any loss of height. And to balance this, on the opposite side, there is loss of height again. And this continues over a period of time. This is the source and cause of degenerative scoliosis that we see in adult population. So asymmetric degeneration, so the same degenerative cascade in an atypical fashion, in an asymmetric fashion, can lead to degenerative scoliosis. And when you have a degenerative scoliosis, what will happen on the foramen on this concave side? The foramen becomes narrow. So the patient has pain because of this instability and deformity, and leg pain because of the foraminal narrowing. So in a early degenerative scoliosis, this is the kind of picture you see. But if it is neglected, you can see a patient with this bad a deformity. So these patients need to be treated as early as possible when they become symptomatic. Again, so not only do you get degenerative scoliosis, you also get degenerative kyphosis. So normally, the lordosis of the lumbar spine is to a large extent a function of the shape of the intervertebral disc. So with age, when the discs degenerate, the discs, they lose height. When they lose height, the lordosis is lost. So you must have been seeing these reports where it says lumbar lordosis obliterated. And in extreme situations, from not only being obliterated, you get what is called as a lumbar kyphosis or a flat back. And that can lead to a domino effect wherein the patient gets a global kyphosis. And this is not good. This takes a lot of energy of the patient and can be a source of significant discomfort and pain. So if neglected over a period of time, so what happens is once the lumbar spine starts degenerating, it becomes flat first, and over a period of time, because of a domino effect, it starts leaning forwards. And these flexors take over extensors if your extensors are weak. And this is very common in our Indian patients where they do not exercise. And over a period of time, the flexors take over so much that the patients end up with a global deformity such as this. And this is also aggravated by patients' osteoporosis. So there is disc degeneration which causes loss of height in the disc space, and there is osteoporosis which leads to multiple compression fractures, which leads to kyphosis. A combination of poor extensors, degenerated at the back, and degenerated discs, and multiple compression fractures because of osteoporosis in the front leads to global kyphosis. And this can be very, very disabling to the patient, not only from the back point of view, but also from the general health point of view. So this is called the zone of economy. Okay. Normally, when humans assume an erect posture, they stand within a certain zone of balance in which their torso remains within a certain distance from the pelvis. By doing this, energy expended by the postural muscles is minimized. So if you're in this particular zone, you're spending the least amount of energy to maintain your posture. So if you go beyond this zone, the zone of economy, the energy expenditure rapidly increases, and eventually spinal misalignment results, and external support such as a cane, crutch, or walker may be necessary. Okay. So this is the reason why we do deformity correction in adult patients, so that not only is their spine symptoms taken care of, but also to improve their, to minimize their energy expenditure. This is called endurance, to improve their endurance. Unless you are Michael Jackson, whose body is tuned totally differently. So I thought I'll flash a few slides on how to read X-rays and MRI. So this is a normal looking spine. It's always important. So if you are the ones who are ordering or prescribing X-rays to the patient, make sure that you advise them to get standing X-rays done. Okay, we need, just like the knees, we need standing X-rays in patients, because most of them they're usually generally comfortable in lying down position, and most of the instabilities, deformities, etc. Subtle instabilities can only be picked up on a standing or a weight bearing X-ray. So what would one should look for is, the shape of the vertebrae. Okay, any so this is the way you can detect a subtle compression fracture. Okay, and end plates. End plates are important because that is, if there is any infection, it usually starts in the paradiscal area. Whether it is tuberculosis, spondylitis, or any kind of infection, it starts in the paradiscal area. So it's very important to appreciate that the end plates are clear and straight. Look for any disc space reduction. It is impossible to diagnose disc herniation on a X-ray. You can't see the disc. So many a times you can see reports wherein it's mentioned that the patient has disc herniation on a X-ray. It's impossible. Only one can appreciate probable disc degeneration. So from L1 to L5, as you come down, the disc height should keep increasing in across the population. So the disc height at L1, L2 is slightly less than L2-3. L2-3 is slightly less than L3-4. L3-4 is slightly less than L4-5. So increasing height as we go down. L5-S1, it could be different. It is congenitally, it could be of different heights in different people. So if you find that, somewhere in between the disc height is quite short, you can suspect that it is some degree of disc degeneration, wear and tear, not herniation. Okay. And next is the pedicles. The pedicles need to be seen in an AP view. So if there is any metastasis, we can see something called as a winking owl sign. So the spinal tumor takes over the pedicle and the margins of the pedicles are not well seen. It is only seen well on one side. So that is called a winking owl sign. Most of these things have become redundant because, MRI is being used very loosely all over the place. Every patient has an MRI with him or her. So the pars interarticularis is this part between the two joints. This is the pars interarticularis. Whenever there is a break in the pars interarticularis, that is called spondylolysis. And because of this lysis, if one body moves on top of the other, it is called spondylolisthesis. You also appreciate the sacroiliac joints and the hip joints in some liberal X-rays. So MRI takes us to, reminds us of black and white era, because the MRI plates, as you see, they come in shades of gray. So from practical point of view, I'll try to make it as simple as possible. There are two shades. One is T1 and one is T2. Okay, so you get T1 and T2 images, and you get these images in different planes. What are most frequently viewed images are the sagittal and the axial images. So axial images are basically the cross section. And sometimes we look for coronal images. The good thing about MRI is it is not associated with any radiation. So to make things simple, so T1, fluid looks dark. So the spinal canal contains spinal fluid and the nerve roots. So fluid looks dark, fat looks white. So this is white. So the bone marrow is full of fat. So that looks white. Okay. So again, this is a cross section. You can see the this is an intervertebral disc which looks dark. So this is the spinal canal. Okay, and this is the CSF, which is dark. Okay, significance of T1 is, since the vertebral body looks white because it has a lot of fat content, infections and tumors which initiate usually in the vertebral bodies, they're easily picked up. So this is edema in the bone. So it could be as a result of infection, or it could be a tumor, or in fact it could be even trauma. So trauma can cause osteoporotic compression fracture can cause edema, and that is very well seen on T1 image. So in a T2 image, what is seen on a T2 image? Fluid looks white. Okay, so the nerve roots are seen gray in both T1 and T2. You see here. So these are the nerve roots. So these are the nerve roots. So they are seen gray in both T1 and T2. Fluid looks white. Okay. So the nucleus pulposus, you see, the nucleus pulposus is white. Okay, as long as it is jelly-like, as long as it has water content, it looks white. So this is the axial section or the transverse section. You see the jelly in the center. So this is nucleus pulposus, and this is annulus fibrosus. Okay, all hard structures are seen black. Okay, so this is about T1 and T2. Now, see, compare the images on the left to the right. So the image on the left, so the sagittal image, it shows that all the discs are white. Okay, you see all the discs are white. That means they are well hydrated nucleus pulposus at all levels. Okay, but here if you see on the right side, 3 of them are gray and the lower 2 are dark. So dark means these are degenerated. The nucleus pulposus is as hard as the annulus is. Okay, so that's why it's looking dark. So there is no water content. It has lost its water content. So this is disc degeneration, and correspondingly, the disc height is also decreased. So whenever there is degeneration, generally there is loss of disc height. So it very well goes with both the issues, that is loss of nucleus pulposus and loss of disc height. So that means there is some degeneration. So how does the same thing look in axial sections? So here you see the nucleus pulposus is very well seen. Okay, white. Here you can see there is significant loss of nucleus pulposus. That's why the whole thing is looking dark. Okay, so degenerate disc looks dark. Okay, a degenerate disc is different from a slip disc or a herniated disc. And this is the spinal canal. Okay, as you see here, the roots are lying posteriorly, and these are all the roots here. You see, these are all the roots. So when there is spinal canal stenosis, what you will see is this whole canal is narrow, which I'll be showing in the succeeding slides. So this canal will look narrow. Okay, and when there is herniation, you will see a part of the nucleus torn and the disc fragment coming out. So that is herniation. So this is how the disc degenerates from a white, pristine white disc. It becomes dark and shriveled with wear and tear. Okay, and this degeneration can cause a loss of shock absorbing capacity. It decreased the ability to transmit weight, and this in turn causes increasing pain and stiffness. So as we discussed initially, so the anterior column takes load when you're bending forwards. So this is what happens in a patient who has a degenerate disc. Forward bending or loading of the anterior column when you sit for long is not borne by a hard or a degenerate disc. So that's why people complain of pain. So coronal images have some rare indications, one of which one good example is to diagnose sacroiliitis. So that is, you need to compare the sacroiliac joint on both sides. So this is a left-sided sacroiliac joint. So this is the iliac side, this is the sacral side, this is the joint line. This is how it looks normally. Okay, and here on the other side you can see there is periarticular edema. So diagnosing SI joint arthritis or any condition affecting the SI joint, such as infection, etc., can be best picked up on a coronal image. So let's see some clinical scenarios and see how you and we as surgeons can help these patients get over these conditions. So this is a very commonly seen situation which you and we see in our practice. So this is a male, 40-year-old male who is an executive in office. His is a sitting job, and he's been doing it for years together. He sits for more than 10 hours a day continuously, and over a period of few months he's developed significant back pain, and this back pain comes about on sitting and for about 15 minutes, and as soon as the pain starts he needs to get up, and the only comfortable position is either lying down, or a less comfortable position is when he stands up and puts supports his back with the palms of his hands. So what are the clues here as to what is the cause of pain? So he's a young patient, so probably he's in the stage of disc degeneration, and the pain comes on forward bending. So that is because he's loading his intervertebral disc. So most probably it is a discogenic pain of degeneration. So when you do a MRI, so this is what you see, a L4-5 disc which is degenerated, looking black. So how do you help this patient? So what is happening here is basically the extensors are overpowered by his flexors. Okay, so lack of exercise, prolonged hours of sitting in a slouched posture has led to weakening of his extensors, and the flexors have taken over, and he gets relief on lying down. That means in extension he gets relief. So possibly by strengthening his extensors and training him to adapt the right posture, you can relieve him of his symptoms. So that is the idea behind that is the idea behind probably advising extension exercises for such patients. A similar scenario, this is not very uncommon. This is seen in adolescent and middle-aged patients who come with back pain. Now, the intervertebral disc is a nerve vascular structure. Unlike other structures in the body, it is totally avascular. There is no blood going into the nucleus pulposus. So whatever nutrition the nucleus pulposus gets is through the diffusion from the vertebral bodies. So there is diffusion of solutes and solvents across these end plates. These are called end plates. So there is a superior end plate, there is an inferior end plate. So the diffusion across these end plates into the vertebral body gives nutrition to the intervertebral disc. So whenever you see such breaks, so these are called Schmall's nodes. You must be familiar with this term. Schmall's nodes, whenever there is a break in the end plates, these are called Schmall's nodes. There is interference with this diffusion, and the metabolism of the intervertebral discs is interfered with. So these discs are not healthy. So they are not resilient because of poor nutrition. And again, this can cause a flexion dominant pain. So because the discs are, as discussed many times, as the discs are in the front, that is anterior column, whenever there is a flexion movement, so they cannot take any pain. They cannot take any load in flexion, and this is declared as pain, flexion dominant pain. And again, these patients are best treated with, again, poor extensors add to it. So these patients, we usually advise them to undergo extension strengthening exercises, so to strengthen their extensors. Again, patients who have annular tears, again, this is a flexion dominant pain. It is anterior column, and this is called a HIZ, hyperintensity zone. So this is edema in the annulus. This is because of a tear. So the nucleus is in the center, the annulus is in the periphery, and any tear in the periphery is called an annular tear. It can be in the center when it causes significant back pain, or it can be on one side when it can cause a referred pain to the legs. Again, the same principle. Since it is a flexion dominant pain, apart from postural rehab, extension exercises is something which we advise in such patients. Similarly, conventionally laminectomy, a wide laminectomy, after a long, following a long incision and retraction of paraspinal muscles, had been the principle of treating lumbar canal stenosis, which is totally changed now. I'll show you in the next few slides. So we get a lot of patients who are operated in 1960s, 1970s. We had undergone a wide laminectomy using a very long incision with significant scarring of muscles. You can see here the significant scarring of muscles. You can see the spinous processes here. They are totally gone here. So there is no musculature. It's all scar tissue. There is no bony elements at the back. So this is what is called a failure of tensile surface or the failure of tension band. So when when the posterior tension band fails, there is increased load on the compression side. So when there is increased load on the compression side, see, the back becomes kyphotic. So again, there is increased load in the anterior column. These patients have significant pain and disability. Again, this is a failure of anterior column because of a failure of posterior tension band. And again, because the patient is going into kyphosis, we advise extension strengthening exercises in such patients. Another case scenario, this is a young patient with severe right leg pain with associated paresthesia of about 15 days duration. So this pain is aggravated with sitting and forward bending and totally relieved with rest. So this patient is extremely in pain, and if you do his x-rays, there is scoliosis. And this scoliosis is not structural scoliosis. This is as a result of protection. So he has so this is a transverse section of the MRI. This is sagittal section. So the last disc, that L5S1, it is degenerated and a part of it has come out into the canal. Remember, as we discussed, this is a spinal canal which has the spinal roots and this is the CSF. Now in the cross section, you see these are the roots here. You can see these dots here. These are the nerve roots, and this disc has come on the right side. Okay, so this conventionally when we MRI is done, so we see the sections are such that this side is right and this side is left. So you're seeing from the caudal side. You're not seeing from the cranial side. So there is a herniation which is more on the right side. Now, because the herniation is more on the right side, it's touching the right nerve, so the patient tends to go to the left. So this is postural, or this is a protective scoliosis to relieve himself of his pain. He's not able to stand straight. When he tries to stand straight, there's irritation of the nerve, which again pushes him back to the left side. So this is typically seen in disc herniations, and this is usually flexion dominant. So these are the various kinds of disc herniation. This is called a contained disc. So the disc is herniated, but it is contained within the annulus. You see here, the nucleus pulposus is out, but it is within the annulus. So this is a contained disc. Okay, this is what is seen here. And this is a sequestrated disc. Okay, the disc has torn the annulus and come out into the canal. It is migrated down. So this is called a sequestrated disc. Okay. So because the disc is dark in color, black in color, and the CSF is white in color in T2, we usually tend to see T2 images for a lumbar disc herniation. In T1 image, everything would look dark, because as you said, liquids look dark. So the CSF would also look dark. So that is why we see black against white. The contrast is best seen in a T2 image. So depending upon where the herniation lies, so suppose it is a L3-4 herniation, so then it will have pain along the L4 dermatome. If it is a L4-5 disc, it will be around the L5 dermatome. If it is a L5-S1 disc herniation, it will be along the S1 dermatome. Now, the natural history of, so this is where your role is very, very important, because, disc herniation doesn't mean surgery. 90% of these patients get better with time. In the first 3 months, 60% of them get better. So almost 2/3 of them get better in the first 3 months, and the rest another 3 months. It's only 10% of patients who continue to have pain even beyond 6 months, and they usually end up in surgery. So that is because the human defense system is so strong that the disc herniated, the herniated part of the disc is chewn up once it enters the spinal canal. So that is the natural history. So so how do we manage these patients? So there are two types of patients that we see. The most common are the ones who have just pain and paresthesia alone without any motor weakness. On the uncommon side, we had a patient just last week. In spite of COVID, so this is one emergency which we need to, in spite of the COVID pandemic, we need to jump into the OT and handle these cases. Is wherein so probably now we can divide this particular slide into two parts. A COVID a case and a non-COVID case. COVID case is one wherein you cannot postpone in spite of the pandemic. That would be a patient who has a cauda equina syndrome. So we had a patient. Actually, the patient was sent by a very, very sensible senior physiotherapist to me because he was his neighbor. And within a fraction of a minute that the patient revealed the history to this neighbor who was a physiotherapist, he called me and sent the patient. And within a fraction of a minute, the roads were empty. He came quickly into the hospital. The MRI department was empty because hardly any patients. So this patient went into the MRI straight away, and he was told to be nil by mouth right from the time he left his home. So within a matter of 6 to 8 hours, we operated on him. So this patient had cauda equina syndrome. So cauda equina syndrome is wherein, because of a massive disc herniation, there is weakness in the ankle foot. It can be as bad as grade 0, along with urinary retention. So this is one situation wherein you need to jump in and operate immediately. Other would be a foot drop, and third would be a worsening neurology. So for all this, for all the red flags, you guys are very, very important, because when the patient on the left side, the non-COVID patients, in the sense the patients who don't need emergency surgery, who have a favorable natural history, in case any of them develop the red flags during their physio, during their rehab, you are the point of contact. So you can pick up any weakness that can stem up in their lower limbs. You can pick up any history which pertains to their the bowel bladder incontinence and connect with us. So these are very, very important, because this can be totally unfavorable to the patient if surgery is delayed in the red flag group. On the common side, that is patients who have mainly pain with or without paresthesia, without any weakness in the lower limbs, they can wait for natural history to resolve their pain and discomfort. Analgesics, physiotherapy, root blocks, these can act as catalysts to enhance their recovery, take care of their pain and discomfort during this period when the natural history is resolving their symptoms. Surgery only in those patients who tend to have significant pain which is coming in the way of them returning back to.
Thing is, I was kind of requesting you because even थोड़ा बोल रहे हैं
मैं किसी को एक्चुअली हमारे को एक्सप्लेन नहीं कर पा रहे, क्योंकि मेरे पास ऑप्शन नहीं है, बिकॉज़ ऑफ सर्वाइवल नीड नाउ. लेक्चर खत्म कर मुझे क्वेश्चन.
Yeah, there's some disturbance. Should I go ahead?
Yes, sir, you can.
So here physiotherapy has a significant role. One is management of pain with various modalities that you people have. You are better equipped with what needs to be done at this stage and how. And you are the one who can teach them posture and activity discipline, how to get in and get out of bed, how to carry out their day-to-day activities without much discomfort and pain. You can gradually start, graded back extensor strengthening exercises in these patients, again, because it's a flexion dominant symptom. And again, as I discussed in the previous slide, you are the point of contact. You have the opportunity to review clinical symptoms, especially the red flags, and assess neurology on a routine basis with the patient and coordinate with the specialist. Now, when it comes to post-surgery, post-discectomy rehab, some of the principles are still very, very ancient, because in many places still, even in advanced metro city like Bombay, people still undergo open surgery. So if you see here, the incision is about 2 to 3 inches long. The paraspinal muscles are torn apart, spread apart. you do a typical, laminectomy to remove this particular disc. So the amount of morbidity that is caused with open surgery is quite significant. So you see, one crucial common entity that physiotherapists and minimal access spine surgeons cherish is the thick bundle of paraspinal muscles. You don't want this to be touched at all. You want this particular band of muscles to be totally unscarred, unscattered. And when you do open surgery, you're basically extremely unscrupulous, and you tend to injure these muscles. And when you repair them, they're never as normal as they were before. So, so this is how an open surgery is done. So you take your skin incision, you go down, you cut the fascia, you cut the paraspinal muscles, go down to the bone, make a window in the bone, that is called a laminectomy, then remove the disc. While the same thing is achieved, using these tubular retractors. So these tubular retractors are inserted using these dilators. So this is what I do. So you pass a series of dilators and then, pass the final tube. So these dilators dilate the paraspinal muscles. They do not cut the paraspinal muscles. And once the tube is removed, these paraspinal muscles fall in place. So there is no injury to the muscles, and the incision is hardly about 10 to 20 millimeter, depending upon the indication of surgery. So this is where probably we can gel, the minimal access surgeons and the physiotherapists, because there is no scarring of the muscle at all post-operatively. So this is a patient with a disc herniation, you can see. So there is a left-sided disc herniation at L5S1, and this is excised using a tube which is about 12 millimeter in diameter. So this is just one stitch. So this is the disc fragment which has come out. I'll just show you a video. So this is directly, we bypassed all the layers of the back and right on the lamina. So that is the flavum. So there's no muscle injury. You go straight on the business area, that is on the lamina. You do make a small hole in the lamina using the drill. You cut the flavum. So once the flavum is cut, all that you need to do is use this instrument called nerve hook, and just turn it around. The disc fragment comes out. So this is a sequestrated disc fragment. So as it comes out, so this is a nerve root here. The structure here is a nerve root. So that is achieving hemostasis. So that is the size of the incision. So this diameter of the tube is about 12 millimeters. So this is a patient who had undergone a L5S1 discectomy long back in 1970s. And he developed a disc herniation at an adjacent level L4-5. This was done using this particular tube. So that is the difference in the degree of trauma, which you can judge by the degree of trauma that is happened inside by looking at the size of the skin incision and comparing. So now we also do this under local anesthesia. The patient doesn't have to be induced under general anesthesia. So here we are doing this discectomy under general anesthesia. The patient doesn't have an endotracheal tube. If you see, she's just on oxygen, and I'm chatting with the patient when operating. So her husband is a real estate agent. I'm chatting about the cost per square feet, etc. So immediately after the surgery, the patient is made to walk in the recovery. And this particular technique, minimal access technique, is extremely of significance in obese patients such as this, wherein you can imagine the length of the skin incision that one would have to take if one were to do an open surgery. Again, this is an interesting paper from Korea. So this is a patient who's undergone a minimal access surgery on the left. So you can see this thick paraspinal musculature at the back. Okay. So this white structure means fat and scar tissue. Okay. So this is non-specific tissue, connective tissue, but this is muscles. This is a patient who has undergone minimal access surgery, and this is a patient who's undergone open surgery. You can see all this paraspinal musculature has been replaced by this bone edema and scar tissue. So that is, so minimal access, so this makes rehab very, very fast. So minimal access surgery, you can start, with most of the rehab, back rehab, immediately after surgery. You don't have to wait. So ultimately it boils down to which one do you prefer. So these are paraspinal muscles. They are split apart when you do an open surgery, compared to this technique where the entire envelope of paraspinal muscles is kept intact. You see, just the tube goes in and the tube goes out. So again, the principles are the same. One should always remember that the anterior column takes significant amount of load. Okay, so when you do a discectomy, the forces continue to remain the same. So it will be still a flexion dominant condition. So the goal of surgery is to prevent recurrence. So once you have a disc herniation, there is about 5 to 15% chance that the fragment of disc which is left inside can come out again. We don't remove the entire disc, we remove the fragment which is herniated out. So that part of the disc which is intact can come out. So this is called recurrence. So one aspect of post-discectomy physio and rehab is to prevent recurrence, and second is to minimize back pain. So because the disc to a certain extent is emptied, there's no much supporting disc inside. So we need to strengthen the back muscle so that they take the load. So basically the emphasis is on back extensors again. And once over a period of time, once the back extensors become strong, concentrate on the cores. At the same time, patients have some degree of lower limb weakness. We need to strengthen their lower limbs. And most importantly, mobilization is immediate. So during our PG time, about 25 years back, these patients were mobilized after 15, 20 days. But currently we mobilize them in the recovery itself after surgery. The next case scenario would be this particular familiar condition that we see in our practice. So this is an elderly lady. She has bilateral buttock pain of about 7 to 8 months duration. The pain goes down to the legs. There is no much back pain, and this pain comes about by walking and standing, and it is relieved with sitting or bending forwards. And there is also some paresthesia in the lower limbs, and distal pulses are well felt. So this is case of lumbar canal stenosis. So these patients, this is called a shopping cart sign. So when they extend, so when they stand straight or when they walk, they get pain in their, the foramen close. In the foramen close, they get pain in that particular dermatome. Okay, and when they bend forwards, the foramen open up, so they get relief. So that's why they tend to hang on the on their shopping cart. So this is in an elderly lady. So the clues to diagnose this is an elderly lady. So she has reached the stage of stabilization. So when you reach the stage of stabilization, you have back pain, if at all, because of facet arthritis, and you have leg pain on extension, that is because of foraminal compression, because there are osteophytes formed, because there is loss of disc height, there is loss of foraminal height, and when they extend, the foramen
Sir, we can't hear you. Actually, he has muted, I think that's why.
Since when?
Since you showed this X-ray of lumbar stenosis and spinal stenosis, you were
Just this
not
slide,
heard.
right?
Yeah, just this slide. Yeah.
So this is a, so if you see here, this is a wide canal here. Okay. This patient has a normal, this is a normal looking MRI. So the discs are intact, the vertebral bodies are intact. There is abundant space in the spinal canal. So same is seen in the axial section. So there is, it's a wide canal in mediolateral dimensions and anterior-posterior dimensions. You can appreciate that. Compare that with this situation here on the right side. So there is hourglass constriction at various levels, okay, and there is no flow of CSF. So this is stenosis. And again, if you see the cross section and compare it with a normal on a normal section on the left side, so the canal is extremely narrow. So this is a case of spinal canal stenosis or lumbar canal stenosis. So when the patients extend, it becomes further narrower, and that causes symptoms. So again, because so this is one of the most commonly seen pathologies in elderly patients, and this is a leading indication for surgery in elderly people. So this is stenosis. So management, basically patient has pain on extension, okay, and that is when the patient stand, walk, even sometimes when the patient is supine, they get these symptoms in the legs, and they get relief with forward flexion. So they usually tend to bend forwards. They tend to when they lie down in the bed, they would say the most comfortable position is lying on the sides, a fetal position. So basically the goal here, since they get pain on extension, you want to beat the extensor. So you want to strengthen the flexor muscle so that they can, open up the foramen. So that is why here we concentrate on flexion exercises, and many, about 50 to 60% of patients get better. When the same patients complain of back pain, it is basically of facet origin. And again, for facet arthritis, we advise flexion exercises to separate the articular surfaces. Again, in obese patients, MIS is of a big advantage because these conventional surgeries. You saw a case of post-laminectomy kyphosis. The conventional laminectomy can be quite morbid on these patients. So they are associated with long incisions, significant blood loss, extensive bony resection can cause instability and back pain. From a short-term point of view, these patients have to stay long because you need to keep a drain, a catheter, etc. And because they might develop spinal instability and post-laminectomy kyphosis, they might need fusion, second surgery later on. So again, all this surgery is done, all these goals of decompression are achieved using these tubular retractors, which I showed initially. So without removing the spinous process, lamina, without torturing the paraspinal muscles, without causing any collateral damage, through these tubes, you can open up the canal. So this is a patient, you see, this is a cross-section T2 view of a patient with canal stenosis. So this is all ligament hypertrophy. So this is causing narrowing of the canal. And these are paraspinal muscles, which are very, very important from a rehab point of view in elderly patients. So what we do is we use these tubes through which we decompress. So after that, you see, the canal is totally free. You can see all the nerves here, but there's no damage to the paraspinal muscles. So without doing a wide laminectomy, one is able to achieve decompression. So this is how it is done. So this is, we drill the lamina on one side. We tilt the tube to the opposite side. And these are all this is the dural sheath containing the nerves. So you can see this is all the neural structures. So you don't need to take a long incision. You don't need to cut the paraspinal muscles. You don't need to put big retractors. So just by tilting and moving these tubes under the microscope, one is able to achieve an adequate decompression. So the nerves from that end, opposite side to this end, can be easily decompressed and visualized. So this is the size of the scar. So these patients can be made to walk the very evening of surgery. So this is an example of an elderly lady who had stenosis at 3 places. You see, this is a canal here. So at 3 places, 1, 2, 3, you see there is hourglass constriction. So there is a narrowing at these 3 levels. See, using one incision by tilting the tube at multiple places, all 3 places, we could achieve decompression. This is on the evening of surgery. She was an elderly lady. She had diabetes. She had hypertension. She had renal failure. She was extremely obese. She has osteoporosis. And if you do an open surgery in such a patient, you would have had to take a long incision, which is as big as this, about 10 to 12 centimeters. And not only that, the amount of muscle trauma that one would cause would be abundant. That was all achieved using a 2 centimeter long incision using these tubes. This we have described in many textbooks at different levels. Now we just spoke about all stable conditions. Now I'll talk about the few unstable conditions that we see in practice, which everyone is curious about. This is called spondylolisthesis. This is an unstable situation wherein one's vertebra slips on top of the other, like here. So when this happens, along with that, the entire canal becomes narrow because, along with the vertebra going forward, it also takes the nerve roots with it. So there are 2 types, which are the most commonly seen types, the degenerative variety and the spondylolytic variety. The other ones are not so common. So we'll discuss about these 2 common varieties. So degenerative spondylolisthesis is the commonest kind of spondylolisthesis. The situation is similar to lumbar canal stenosis. Here, when the vertebra slips forward, the entire ring goes with it. Okay, the vertebra, the pedicle, the vertebral body, the pedicles, the laminae, they form a ring. The entire ring goes anteriorly, and because of which there is kinking of the nerves. Okay, and the reason for this is disc regeneration. It is most commonly seen at L4, L5. So here you see the entire vertebral body has gone along with all the elements. The entire ring has gone forward, because of which there is compression here. You see here there is an hourglass constriction here. So the disc is compared to an inflated balloon. So when the disc degenerates, okay, so this part is the superior vertebra, this plate is the inferior vertebra, and this is the intervertebral disc. So when the disc degenerates, it loses height. When it loses height, the ligaments in the front and at the back, they lose tension. When they lose tension, because of the shear force, the force is acting antero-inferior. You can see this is the line of forces. Okay, so for example, if you go to previous slide, this is the line of forces. Because of that, there is eccentric loading of this hollow balloon, and that's why the L4 slips on top of L5. So when that happens, you get 2 things. One is significant facet arthritis. Okay, see here L4, L5, and because of this slippage, there is also foraminal narrowing. So there is a kinking of the canal, narrowing of the foramen, and there is facet arthritis. So all this can cause back pain as well as leg symptoms, such as back pain because of facet arthritis and instability. You can see there the L4 keeps rocking on L5. So because of instability and facet arthritis, one gets back pain, and because of the kinking of the nerves and narrowing of the foramen here, okay, one gets leg symptoms, basically neurogenic claudication. So initial treatment, is basically medication, physiotherapy. We advise again flexion exercises in these patients because of 2 reasons. One is, you see, this is flexion and this is extension. So in extension, the foramen is narrower compared to flexion. And again, these patients complain of leg pain mainly on standing and walking, similar to the patients with lumbar canal stenosis. So that's why we advise flexion exercises in these patients. This opens up the foramen and the articular surfaces at the facet joint. Okay, so this minimizes the friction there, flexion. When they extend, the articular surfaces come closer. So when you flex, they move far away. So that is the reason we advise core strengthening exercises in these patients. And when it comes to surgery, I got a feedback that many are interested in knowing the implants that we use. This is how we stabilize the patient's back. So what we do is we, decompress this foramen. So using the same tubes which I showed you, we decompress the foramen and stabilize it. How do we stabilize? So we put screws. So these screws go through the pedicle. So these are called pedicle screws. So L4 and L5, we get anchorage in the adjacent vertebra and we pull L4 behind. You see here, L4 is going forwards on L5. So we put screws in L4, we put screw in L5 and we connect with the rod. So it gets aligned. So you can imagine the kinked nerve roots, they all move backwards and the spinal canal comes in line. Okay, so this white line will overlap on the white line below. Okay, so that means the nerves are back in their place and the foramen are open. And once the pedicle screws pull this L4 back, we need to fuse L4 to L5. Okay, we don't want it to go back again. So that's what we do is we remove the disc in between and we fill it with bone. This bone is filled with something called as a cage. Okay, that is what a cage is. The cage is used to fill bone. So this is how fusion happens. So there is a column of bone found between these two vertebrae. So this is called decompression and stabilization. Again, generally it is done using an open technique. So again, you cut the skin, fascia, paraspinal muscles, go down and do the entire procedure. Just like here, you see, this is the skin. This is the fascia and fat. This is the thick bundle of paraspinal muscles, which are very, very important, for functioning of our back. So when you do an open surgery, to put these screws and to perform the decompression and fusion procedure, we have to strip the paraspinal muscles apart. And you see, you leave such a big dead space behind. Okay, and then you have to close them. But when we do it, the whole thing with minimal access, these screws are passed percutaneously without cutting any of these layers, without causing any instability or collateral damage to the structures which are not concerned here. So the paraspinal muscles are left intact. So that is the beauty of minimally invasive spine. Again, I'll show you the procedure in the next few slides, the video. And the other type of spondylolisthesis that we see is the spondylolytic listhesis. So here the ring is not intact. So there is a pars break. So at the level of the pars, there is a break because of which the vertebra above slips on top of the vertebra below. And this is commonest at L5-S1. And unlike the disc being the cause here, the cause of spondylolisthesis is dysplastic. It has something to do with the weak pars interarticularis at L5-S1. So this is a case of L5-S1 lytic listhesis. You can appreciate here, there's a break in the pars because of which this L5 is slipping on top of S1. So with time, this spondylolisthesis progresses. You see, this is a patient who serially had these X-rays done. So in 1986, this was the disc height, and the degree of listhesis was grade 1. And over a period of time, as the disc got degenerated, the spondylolisthesis progressed. From grade 1, it came to about grade 3 here. So this progressed with time. So this is an MRI of a patient who had significant back pain and leg pain, claudication pain. But when the MRI was done, as you see here, all the vertebral bodies were intact, the discs were intact, and there was no compression on the nerves anywhere. Okay, So the patient had clear symptoms of back pain and leg pain, and she went from one doctor to the other without any relief with this particular MRI. So when she came to us, what we did was we did a standing X-ray. Okay, the standing X-ray showed instability here at L5S1. Okay, this is to basically pinpoint the fact that we tend to forget the basic investigation that one needs to do. Okay, so start with X-rays first, and when it's very important that you do a standing X-ray. If you're lying down, X-ray is done, maybe this L5S1 listhesis will reduce in extension. So even that may be missed out. So here you see, because the MRI is done lying down, so there was no listhesis seen here at L5S1. Okay, only a standing X-ray revealed the L5S1 listhesis. So it's very important that you do a standing X-ray and start with basic investigation, that is the X-ray. Another patient again. So you see here, patient has significant back pain. That back pain can be explained by this degenerated disc. That is fine. But patient also had a leg pain, and that too in the anterior aspect of the thigh. Okay, the MRI looked normal. X-ray was never done in this patient. We got an X-ray done, standing X-ray. You see there is a spondylolytic spondylolisthesis at 2-3, and correspondingly well, it does correlate with her anterior thigh pain. Okay, so never was her MRI done, and she was going from one doctor to the other with no relief at all. She was even went to a psychiatrist. So again, the management is the same. So we advise medication. We again, when we send the patients to our colleague physiotherapists, we advise flexion exercises. The reason being, again, you see in flexion, the foramen opens up. So the foraminal narrowing is seen in extension, and it improves in flexion. So that is the reason, because it opens up the foramen. Again, it opens up and distracts the friction at the pars. When there is a pars break, the surfaces of the pars interarticulars where there is a break, they are all rough. So when the patient extends, they get pain. So that is the reason we advise flexion exercises in these patients. And ultimately, the final answer is again stabilizing fusion at that particular level. Again, the principles are the same. We advocate minimal access fusion in these patients. So I'll show you a short video. So how the entire surgery is done without taking a midline incision, without actually seeing the entire spine. So this is done using navigation. So this patient has spondylolytic you see the pars break here. So this is spondylolytic spondylolisthesis. So what we do is we put screws in L5 and S1, pedicle screws, and we connect it to the rod and remove the disc between L5 S1 and put a cage filled with bone graft there. So this is using navigation. So what we did initially was, so once the patient is positioned on the table, this is the intraoperative CT scan. So this is a C-arm which gives CT scan images intraoperatively. And looking at the monitor, we insert these guide wires all under navigation control. So that shows exactly, so you see it's going in the pedicle here. The pedicle, which I had shown in the initial axial section. So if you see here, there is no skin incision. So it's all done percutaneously. So this is the tap. You see, this is the pedicle through which the tap is going. This is basically to make a hole for the pedicle screw. So this is how a screw is passed. This is a tubular retractor through which we excise the lamina. So that is the intervertebral disc. So this is the bone graft. So the disc space, so this is called a cage cutter. So now the rod is passed to connect the two screws, and the L5 screw is pulled back along with the L5 vertebral body to get reduction. Now this is called the cage. So that is filled with bone graft, and you put screws on the opposite side. So you have 4 pedicles, 2 pedicles at L5, 2 pedicles at S1. So you put 4 screws, 2 on each side, and connect with the rod. So these are the small keyholes through which the entire surgery is done. So, we can keep talking about spine forever. We just discussed a few degenerative conditions. There are so many other etiologies like trauma, infection, congenital conditions, etc., which we can keep discussing forever. So there are also other regions of spine, that is the cervical spine, the thoracic spine, etc. We can keep talking about scoliosis, deformity, kyphosis, etc. But that will keep going on and on. Maybe if you guys are interested, we can have another session on these particular topics. So we'll call it the end of the day. I'm free to take questions. So I don't call it a take home message anymore because we are all at home now. So it's a take clinic message. So the foundation of treatment is based on understanding the anatomy and biomechanics of spine. Every condition needs a different perspective and different weapon to treat. And without physiotherapy support, surgeons are just empty glasses. Thank you.
Hello.
Yeah.
Thank you so much, sir. It was a wonderful session we had. So there are some questions, sir. There are a lot of questions, but we will take 2-3 questions as it is we are running now with time.
Okay.
So first question is, sir, can you go on your chat and see the question?
Yeah, sure.
Sir, stop doing sharing of the screen.
Okay. So, minimally invasive lumbar procedure, patients are instructed to, so where do I go?
So yeah, okay, you can take that question. That post minimal invasive lumbar procedure, patients are instructed not to bend or do lumbar movements, not really given time frames until when. So, hence, patient becomes so apprehensive to even do mild activities. So, what is the time period basically they want to know?
So after a fusion procedure, see, ultimately the fusion takes about 3 to 6 months, and for it to become solid and consolidate, it will take another 3 to 6 months. So I don't restrict the patient from most of the activities. So as and when they're comfortable, they can do most of the activities that they do, except the terminal movements like bending all the way down, etc. I wouldn't advise them to do for at least 6 to 8 months, so that it allows time for solid fusion.
Okay, thank you, sir. Sir, now the next is Nikita Singhania. She wants to know that there is a 65-year-old female patient who was diagnosed with a spinal canal stenosis with the right leg pain. Post-Laminectomy surgery, she is experiencing again the same symptoms in the leg pain. But it is right now on the left side after the surgery. So, but they are milder symptoms. So, what would you advise in this situation?
So that needs to be analyzed. If the patient if the patient had relief for some time and after which this started, it could be some degree of instability at that particular level, or it could be if it is another dermatome, then it could be stenosis at another level. Some patients have facet pain which can get referred to the leg, so the patient needs to be analyzed.
Okay, okay. Thank you, sir. Anyone wants to know any other questions, please? Okay, I think we are done with the question. Just a
Sir,
second.
there was a
Yeah,
question by
yeah.
Pallavi Chopde. Post-laminectomy and discectomy, when can we start treating neural tightness as the patient for many days is unable to extend the knee because of this tightness?
Yeah, you should start as early as possible, you know. So if the surgery has been done well, and if you have a conversation with the surgeon and the surgeon is happy with the surgery, you shouldn't delay at all. You can start immediately.
Okay.
There is one more. At what stage you prefer epidural, and what will be the cost of epidural?
So the cost I wouldn't discuss, because you know I go to 2-3 hospitals and it varies from one hospital to the other. But so usually for a disc herniation, see, generally, as I said, you know, 90% of them get better with time. So over a period of time, especially about 2 to 3 weeks time, majority of them start feeling some relief. So if the trend is such that the patient is getting better, I won't do it. But at 3 weeks interval, if the patient still has pain, and if the patient is if the pain is increasing, that is the point when I would advise the injection. 3 weeks.
Okay, doctor. If it is a multiple level stenosis, you will go for the one vertebra up and one vertebra down for the pedicle screw fixation, or
So suppose, for example, it is L4-5, okay, which is the most common level, and along with stenosis, if there is significant instability, okay, then I would do L4-5 alone. So if the patient has 3 levels, for example, if there is instability L3-4, L4-5, L5-S1, and all 3 levels are unstable and all are symptomatic, so then we'll have to do a L3 to S1 fusion. So L3, L4, L5, S1. There'll be 4 levels where you would put screws.
I see post-operatively, you will advise any other braces, or you can just advise strengthen the back muscle and go.
Yeah, so the thing is, you know, the patients, they have some psychological connection with this brace. So unless you give them brace, they are not happy to get out of the bed, get back to the bed. And it is so badly drilled into their head. Actually, it is not necessary, but for soft tissue comfort, just like the way we give a cervical collar for a few days after a cervical procedure, from soft tissue comfort point of view, we would usually give a brace till the first follow-up. That is about for 10 to 15 days.
Actually, for my opinion, if it is a pedicle screw, the back is more stronger, right? So compared to the normal people, so it's really, if you strengthen the back muscles, it will be it's not necessary to put the back in the support. Actually,
You're
it's
right.
actually, yeah. And
So
you are doing the most of the cases with the neuro navigation, or selected cases only you are doing with the neuro navigation?
So using neuro navigation for each and every case is a waste.
Yeah,
Economic.
that's what I'm asking. Yeah.
So we do it when it is critically important. We always do when we are doing a deformity correction. That is the highest, you know, risk of. That is one surgery which is a high risk of neurological injury. Though touch wood, we never had a case with any neurological weakness post-op in deformity. One is, as I said, deformity correction. Second is myelopathy, cervical myelopathy. So these are two conditions where we, as well as thoracic myelopathy. These are conditions where we do use navigation without fail.
I see. Thank you so much. Very latest update. Thank you. Thank you for listening. I'm listening from Qatar. Thank you.
Thanks.
Dr. Kulkarni, may I ask you a question?
Sure.
Sometimes patients, they wish to return back to running post an MIS procedure. So the question is, even after they have undergone an extensive rehab program, should they be allowed to return back after a year or so, or not?
Yeah. So I wouldn't withhold them from any kind of sporting activity, but you should discuss, you know, the higher degree of risk of possibility of getting another similar situation at another level. Okay, the kind of discussion I have with such patients is I try to invoke what kind of passion they have for sports. So if they are so passionate that they are ready to go on other surgery if it affects another level, I will give them a green signal to go ahead. But if they are sorry.
If it's more for recreation, then
Yeah. So if they're passionate about it, I would advise them to go all the way ahead. Yeah.
okay, all right.
I think first, when we are prior to surgery itself, if you give a patient education,
Yes,
that will
is
be the
very
outcome. It
important.
will be much better because
Yeah, so-
after the post-op, maybe they will think they cannot move or something. The prior to surgery, if pre-op education, if you give, okay, the day of surgery you will move and the next day you will be discharged. Or if it is lamina, so maybe if you do 1 or 2 days, you can be discharged. So if it is a pre-op education, I believe the patient can be physically and
So-
psychologically, they can prepare, then it will be prognosis for the patient as well as psychologically.
Yeah. So I think it is criminal if you don't counsel the patient preoperatively with regards to patient's expectations after surgery, possible complications, and rehab. You have to discuss all this with the patient.
Yeah.
You have
Because
to
any surgery, there is a 5% of possibility for negative or something. So it's we have. Yeah.
Correct.
Okay, if
Okay, thank
anyone
you
has
so much.
questions, you can message, you can type it on my WhatsApp, and then I can forward it to sir, and I will get back to you people. Okay?
Thank you.
Yeah. So
Thank you.
thank you so much, sir.
Thank you.
And Dr. Gajadan has helped us to coordinate this session. He is one of the best physiotherapists treating spine surgeries and spinal patient. Basically, he's into neurotherapy in Pune. He's an ex-Sancheti, HOD of Sancheti Hospital also.
Okay.
So I
Thank
thank
you.
him for coordinating. Kaju sir, thanks a lot. And sir, thank you so much for having such a beautiful session with us. Really thankful. We are looking forward for more informative sessions with you.
Sure. Thank you very much, Kavita, for organizing this. And Dr. Gajanan, thank you so much.
Thank you, sir. We'll be uploading this video on YouTube. So if anybody has any query in future and you want to refer to this lecture, you can go on the YouTube link. We'll share you the YouTube link on your email ID. Thank you very much.
Yeah, and your friends who have missed on to it also can attend this lecture again. Okay. Thank you, sir.
Thank
you, sir.
Good night, everyone.
Good night.
Good night, sir.